this is an exciting time in prostate cancer. When we look at early disease, a correction was needed. You gave us a way forward, starting with family practice guys. You should screen. You shouldn't give it away. You've talked to get family practice docs. Most of them believe there probably is a benefit for early detection.
Yeah, there was a wonderful study that we did last year where we were asking our primary care colleagues about their thoughts on prostate cancer screening, and we took a couple things out of it. One was this mass confusion. No one really knew what to do. They were looking at guidelines. They didn't even understand the guidelines necessarily, and there's so many, I don't blame them. But what I found very reassuring is, and this was a study with 153 primary care providers, unanimously, they knew that there was aggressive tumors and there were indolent tumors.
Right.
And they unanimously said if we had a way of differentiating those, we would do that.
It's amazing how many primary care doctors I see that check their own PSAs. Mm-hmm. And you have a great talk where you give that U.S. Services Preventive Task Force says don't check PSAs, and then you have the annual history and physical of the President of the United States, and his PSA was like 0.71.
Yeah.
So he had his checked, and he wasn't even in the high,
and that was
8 over 65. Right. So, I think that you're right. And so the take-home message is, and you and I have published a paper on this, you have done a lot of work on this, is that in the heart of hearts, most family practice doctors think that there is a value for early detection in the right person, but we were doing a lot of overdiagnosis and overtreatment. And you've showed that a PSA of greater than 1.5 is a danger zone. What you do, it's like when you get an abnormal blood sugar, you go to the A1C, and the A1C in this area are a couple of new tests, the blood test and the urine test, to try to identify aggressive prostate cancers. So, that's a way forward so we don't have all this advanced disease that's coming around. Dan, I think you did a nice job of talking about all these new agents. We talked about shared care and how you can't do it by yourself. I can't do it myself. You can't do it by yourself. It's a team. It's a team that wins, and that's what the shared care is. And it's not just, radiation oncologists and medical oncologists and urologists. It embraces family practice. And finally, I want to thank both of you for being here. Matt is a unique person in more than one way. He actually is trained in urology in Boston, and he is a family practice doctor, so he has both sides of the fence. There aren't many medical oncologists in the world like Dan Petrylak. He is one of the top, and the issue is we don't have enough Dan Petrylaks around, and so we have medical oncologists who don't know that much about prostate cancer. I mean, they've got other important tumors to take care of. They're, breast cancer and lung cancer and hopefully something in pancreatic cancer. And so, that's why, what you're seeing here is sort of, people that know a lot about prostate cancer, but out in the community, there's the family practice guy and somewhere in South Dakota who's working with the urologist, and the medical oncologist is a team and different. You got to work together. So I want to thank both of you for sharing all this information. I think that we've got a good foundation to work on, and it's the future. We have studies that we didn't even go into from Europe and Sweden that looked at shared care actually improves the survival rate of patients. And that's been shown in many other things, in multidisciplinary clinics and that. So, the idea is that there's you need a team captain, but that varies who the team captain is, but you need a team.
Absolutely.
Any last comments you guys want to make?
No, I think, again, communication is the key, and stay away from email. Use the telephone. I think that's a lot better.
It is. Let's go back to our origins here, and let's commit to communicating, because at the end of the day, it's improved patient care.
All right. Thank you.
Thank you.